So I'm now going to introduce Professor George Kittas from the Dudley NHS Foundation Trust. Over to you, George.
Thank you very much, Emma. And thank you very much, all of you at NRAS. We've had a very, very long association with NRAS, and you have helped us an awful lot with the research work we've been doing in the cardiovascular field, and we continue doing over the last 20 years or so. And it is participation like this which helps us enormously with this type of work, so that we can have this type of meetings and hopefully move forwards, both in terms of clinical management of patients and in terms of better knowledge of what the problems are and how best to address them. I'm going to try and share my screen now. So what I've been asked to talk about today is the concept of cardiovascular risk in people with rheumatoid arthritis. And how we can prevent this problem, how can we monitor it, and how can we best manage it. And I will use several slides which have a scientific content, but I will try to explain things as simply as possible. And of course, we can discuss details afterwards in the question and answer session. So what I will try to cover in the next half an hour or so is what is the problem when we talk about cardiovascular disease in people with rheumatoid arthritis, which are the risk factors for cardiovascular disease, how early in the course of rheumatoid arthritis does the increased cardiovascular risk occur, how do we monitor risk factors in people with rheumatoid arthritis, and how do we manage cardiovascular risk factors. And I will end with a practical approach for the physician, for your doctor, but exactly what applies to your doctor applies to you in challenging your doctor to make sure that whatever issues we discuss are actually covered during the consultation and your follow-up. So what is the problem? Well, we have a lot of studies which compare the mortality in people with rheumatoid arthritis to the mortality of comparable people from the general population, people who do not have rheumatoid arthritis. And if you apply some fancy statistics, what you see is that this is where the general population lies. So one is the baseline from where we all start. If we have a risk of 1 to die of heart disease, what we see is that people with rheumatoid arthritis have a risk which is about 1.5. This means that it is roughly 50% increased compared with the general population. Now, this is an observation which is based on many, many different studies from the early 70s all the way to now. And it is actually quite robust data, and it does not appear to change over time that much, despite the fact that we have made significant progress in managing cardiovascular disease in people with rheumatoid arthritis, but equal or possibly even more progress we've made in managing cardiovascular disease in the general population. So they are shifting in parallel, they are not merging. Now, when we talk about cardiovascular disease, we may be talking about many different types of problems. For example, ischemic heart disease, the problem that causes angina. Heart failure, the problem that usually causes dyspnea on effort, difficulty breathing, or even when you try to sleep. We may be talking about peripheral vascular disease, and this is when the peripheral blood vessels, those, for example, in the legs, get blocked, and this can cause problems, etc. And what we see, in exactly the same way that we see an increase in mortality from cardiovascular causes of about 50%, the same exactly happens when we address all of these individual problems. 50% increase in ischemic heart disease, 50% or probably a bit more in heart failure, 50% in peripheral vascular disease, etc. So this suggests that the increased cardiovascular mortality that we see in people with rheumatoid arthritis is because they have all of these individual problems separately. And what happens also is that what we see in people with rheumatoid arthritis, we also see in people with other types of inflammatory arthritis, such as psoriatic arthritis, ankylosing spondylitis. They behave to a possibly slightly lesser extent in the same way as rheumatoids. And what again this tells us, if we put it all together, is that inflammation most probably has something to do with it. Now, this is a busy slide. I'll spend a bit of time on it because this underpins everything about cardiovascular disease and how it can be expressed in people with rheumatoid arthritis, indeed in everybody. So when we talk about cardiovascular disease, we may be talking about causes of heart disease. For example, high blood pressure or abnormal lipids or being overweight or having diabetes or having inflammation. We may be talking about the effect that these causes have on the blood vessels. And the main effect that they have is atherosclerosis, a process in which the blood vessels are hardened and you have lipid deposition, and it's this that causes them the other problems. But we increasingly recognize that it's not only this atherosclerosis that's the problem, but other problems as well, like vasculitis, inflammation of the blood vessels themselves, dysfunction of the small blood vessels in the heart, or even inflammation of the heart muscle itself, not the blood vessels, but the heart muscle. We may be talking about what these processes cause to the heart and the blood vessels, which are effectively two things only. One is ischemia. Ischemia means not enough oxygen, not enough blood going to the heart muscle because the blood vessels are one way or another affected. And the other is dysfunction. And this means that the heart muscle does not work well, does not work efficiently. It's this that's causing heart failure usually. And this can be, again, due to many different causes like blockage of blood vessels, but also damage to the heart muscle itself. Now, if we have such situations, what we experience, you, me, everybody, could be symptoms. We feel that something is wrong. Now, we may have something like this. We may have problems with our heart and blood vessels, but we may not have any symptoms at all. We and others have shown actually that people with rheumatoid arthritis do not have symptoms of heart problems more commonly than people without rheumatoid arthritis. One possible explanation is because a lot of people with rheumatoid arthritis may not have sufficiently high physical activity to elicit symptoms like, for example, angina or the breathlessness of heart failure. And then, whether we have symptoms or not, we may unfortunately have the eventual outcome, which happens to all of us. The question here is how soon or how late it will happen, which is cardiovascular death or disability. So I'll try to walk you through the nature of the problem. And there are three main problems that can happen to the blood vessels when one has rheumatoid arthritis. These three problems happen to everybody in the general population as well if they have heart disease, but they appear to be more frequently found in people with inflammatory disease. The first is atherosclerosis. This process that I mentioned causes hardening of the blood vessels. Okay. And there is a lot of evidence that this, in people who have any inflammatory condition, including rheumatoid arthritis, happens faster than it would happen in people who do not have an inflammatory condition. The second problem is what we call plaque instability. These are the plaques which are formed on the inside of the blood vessel, made of lipids predominantly. And it's these plaques actually that if they break and get dislodged from the blood vessels, they go further down the blood vessel. Because the blood vessel gets thinner and thinner, they block it completely and they cut off the blood supply to the area of the heart that the blood vessel goes to. Now, if a plaque is stable and does not rupture, that's not such a big problem. I'm not saying that it's not a big problem. I'm saying it's not such a big problem in that a stable plaque is not going to cause a heart attack. But if a plaque ruptures, it can cause a heart attack. And then we may be talking about some other mechanisms, and I will mention them very briefly. So here I am summarizing the evidence that atherosclerosis occurs in people with rheumatoid arthritis, this hardening of the blood vessels, and that it is accelerated. And we have many different lines of evidence which suggest that this happens. A lot of it is theory, and we know now that atherosclerosis, even in people without rheumatoid arthritis, in the general population, is itself an inflammatory condition. Not the levels of inflammation that we see in people with rheumatoid arthritis, much lower levels, low-grade inflammation, but that's inflammation is one of the main ways that the blood vessel is damaged. Then we have a lot of evidence from studies which can assess how well the blood vessels work, both in the periphery and centrally. And again, what we see there using such studies is that the blood vessels of people with rheumatoid arthritis are more frequently dysfunctional than people without rheumatoid arthritis. And age-wise, this appears to start earlier. The third piece of evidence is that in terms of cardiovascular disease, the frequency and the expression of cardiovascular disease, rheumatoid arthritis behaves in exactly the same way as diabetes mellitus. And diabetes, sugar problems, as you know, is now accepted entirely by everybody in the world that it predisposes to atherosclerosis, it predisposes to problems with the blood vessels, the heart, and even strokes. And then we have the last bit, which is a lot of risk factors for atherosclerosis in people with rheumatoid arthritis, such as high blood pressure, such as abnormalities in the lipids, low physical activity, changes in the body composition, and several other factors. And we will concentrate on this a little bit. So there is more than enough evidence that accelerated atherosclerosis is a problem in people with rheumatoid arthritis that can cause heart disease. How about plaque instability? Again, I'm not going to go through this in detail, but we do have a lot of evidence which show that the atherosclerotic plaques, these plaques in the blood vessel in people with rheumatoid arthritis appear to be more unstable than in people without rheumatoid arthritis. And this makes it more likely for a person with atherosclerosis who also has rheumatoid arthritis to have a heart attack compared with a person with atherosclerosis who does not have rheumatoid arthritis. And we also have evidence to show that the instability of the plaque associates predominantly with how much inflammation one has. So if we do our job well and we control inflammation very effectively, we reduce very significantly the chances of a plaque rupturing and causing a heart attack. So yes, plaque instability is also a problem, and we roughly know how to control it. And then there are other mechanisms as well. I'm not going to discuss them at all because we are people who deal with cardiovascular disease research-wise cannot agree between ourselves exactly what's happening there. But what I'm trying to put across here is that we should not only consider atherosclerosis, there are other mechanisms as well, and we do need to do much more research in these other mechanisms which can also cause heart disease and cardiovascular death in people with rheumatoid arthritis. So then, which are the risk factors for heart disease in people with inflammatory disease, with rheumatoid arthritis? Well, here they are. And again, I'd like to spend a little bit of time on this slide. When we talk about risk factors for heart disease, we talk about classical risk factors. These are risk factors that apply to everybody in the general population. And we talk about risk factors that may be related specifically to rheumatoid arthritis, such as autoantibodies, genes, how long one has had rheumatoid arthritis, etc. These risk factors do not apply to the general population. And we also split the risk factors in those that we call not modifiable. These are the risk factors that we can do nothing about. We cannot do anything about our age. We cannot do anything about our sex. We cannot do anything about our family history if we have a relative who has died of a heart attack. And on the other side, we cannot do anything about the autoantibodies that we have or do not have, or the genes we have, or how long we've had rheumatoid arthritis. These things exist. They are risk factors, but we cannot do anything about them. But here in the middle, there is a large group of risk factors, which we call modifiable. And these are risk factors that we can definitely do an awful lot about. We can reduce lipids if they are high. We can reduce blood pressure if it's high. We can improve blood sugar if it's high. We can increase our physical activity if we are couch potatoes. We can stop smoking if we smoke. We can reduce our weight if we are overweight. We can change drugs if some drugs are causing problems. And we can definitely control inflammation, and we can do this much better than we did in the past. So it's these modifiable risk factors that we should be paying a lot of attention to. I'm not going to talk about rheumatoid cachexia, just to mention that obesity, that being overweight in people with rheumatoid arthritis is slightly different to being overweight in people without rheumatoid arthritis. And this is because inflammation causes a lot of loss of muscle, which is unfortunately replaced with fat. So if you have a person, let's say 6 foot tall and 80 kilograms with rheumatoid arthritis, and a person 6 foot tall and 80 kilograms without rheumatoid arthritis, it is likely that the person who has rheumatoid arthritis, although they are of exactly the same height and weight with the other person, they will have more fat and less muscle in their body than the other person. And this can, of course, cause problems then with lipids, with blood pressure, and with blood sugar control. And there are several mechanisms that we and others have studied how this can be caused. Now, in addition to these classical risk factors, there are several other factors that play a role. For example, the drugs that we use to control arthritis can have good or bad effects on the classical risk factors. For example, anti-inflammatories can cause high blood pressure. Not in everybody, but they can do that. Hydroxychloroquine, which many of you may be using, appears to be good also for lipid control and for blood sugar control, in addition to whatever it does for inflammation control. Methotrexate appears to reduce the frequency of high blood pressure, dyslipidemia, poor glucose control, something that we call jointly metabolic syndrome. Steroids, on the other hand, we know can cause problems with blood pressure, with lipids, with blood glucose. And several biologics appear to have to cause alteration of lipids. There are questions about this as far as I can see later, and we can discuss this in detail. But on the other hand, they can improve blood pressure, some of them, or improve body composition. So the drugs that we rheumatologists use for control of your arthritis may have positive, but they may also have negative effects on risk factors for heart disease. And this is something that both we as doctors and you as patients should be aware of and challenge us if you are hypertensive and we give you a drug that has caused an increase of your blood pressure, and you've got to tell us, now we have so many choices, why aren't you using something else? In the same way that you would tell us, why aren't you using something else if your arthritis was not better after treatment X? Let's forget this. Now, the next question is how early in the course of rheumatoid arthritis does cardiovascular risk increase? And the straight answer here is that it appears to be very early on, sometimes even before the onset of rheumatoid arthritis. And this tells us that cardiovascular risk factors should be assessed, and if they exist, addressed almost at the same time that we diagnose people as having rheumatoid arthritis. And again, this is something that patients themselves can challenge us as doctors and the system to achieve. And now let's come to how we monitor these cardiovascular risk factors in people with rheumatoid arthritis, which effectively is exactly the same way that we monitor it in everybody, or we should monitor it in everybody. The first thing we need to do is to monitor individual risk factors. For example, to measure blood pressure and know whether somebody has increased blood pressure or not. And if they have increased blood pressure, and this cannot be reduced with, let's say, some weight loss or some stress management, then we should start medication. And once we start medications for blood pressure, we must make sure that the blood pressure is reduced to normal levels. It's not good enough to have a blood pressure of 160 systolic and reduce it to 150. We should not be happy with this. There are targets in the same way that we have targets as rheumatologists for your ESR or CRP or DAS28 score. We have targets in the general population for how low one's blood pressure should be. And the same, of course, applies to lipids. And the same, of course, applies to blood sugar. So we need to monitor the individual risk factors, which effectively means blood pressure, lipids, blood glucose, body weight or BMI, and I suppose physical activity levels. This is more difficult to assess. Now, I would like to spend a little bit more time on this slide because it gives an important message. We did a study, and many others now have confirmed it, where we took a large population of people with rheumatoid arthritis and systematically measured their blood pressure. And about 2 in 3 people with rheumatoid arthritis had raised blood pressure. But of those who had raised blood pressure, of these 70%, almost 40%, we did not know that they had high blood pressure because they had never measured it, we had never measured it. And what's even worse is that even of those who were diagnosed, we knew that they had blood pressure. Almost 4 in 5, 80%, their blood pressure was not sufficiently well controlled. It was not controlled to the levels that we should be controlling them. Now, we did this study in 2006 and it was published in 2007. And in 2021, we have just published an international audit of blood pressure control in more than 15,000 patients with rheumatoid arthritis from 40 countries, including the UK. And the situation 15 years later remains as bad now as it was then. And this has nothing to do with not knowing what the problem is. It has to do with how we implement risk assessment and risk management in this population. Now, once we have assessed the individual risk factors, we can use, again, fancy statistics, algorithms, to calculate what is the risk of a given individual to have a heart attack or stroke in the next 5 or 10 years' time. Okay. And we need things like the age and gender, whether we smoke or not, whether we have a family history of heart disease, what is the blood pressure, diastolic and systolic, what is the total cholesterol, the good cholesterol. And in some of these algorithms, these systems, for example, the QRisk2 and now the QRisk3, which is used in the UK, we can even put things like whether they have rheumatoid arthritis or not. And then we press the magic button once we've put these things in, and we come up with a figure. Let's say 10%. What does a 10% risk mean of having a heart attack in the next 10 years? It means that if you take 100 people like this, and you do absolutely nothing, in the next 10 years, 10 of them will have had a heart attack, and 90 will not. But if you take these same 100 people and you treat them for, let's say, blood pressure if they have a high blood pressure, for lipids if they have a high cholesterol, etc., then you monitor them, roughly 4 out of the 100 will have a heart attack, and 96 will not have a heart attack. This means that by treating people appropriately, we reduce the risk of having a heart attack by at least 50%, which is significant. The numbers may not be large in the sense that even if we do nothing, most people will not have a heart attack in 10 years, but there will be several that will do. But if we do something, half of these several will have a heart attack, and the other half we will have saved. Okay. Now, once we use these algorithms and we've decided whether we needed to treat or not, the next question is, okay, how do we treat? Generally, there are 2 things we can do. One of them we can do as doctors and suggest to you as doctors. The other one you can do yourselves. We cannot do it for you. The one where we can do things is giving you medications appropriately and suggesting that you may need to change X, Y, or Z in your lifestyle. For example, exercise more or lose some weight. And we may even suggest ways that this can happen. But we should not forget that it is up to us as individuals to achieve this lifestyle modification. We cannot have a doctor with a whip or a physiotherapist or a personal trainer. I suppose we can have a personal trainer with a whip. I've had one for over 2 years now, who can make us do things. Okay. So lifestyle modification is extremely important. I'll say a few things about it, but I want to emphasize right from the beginning that this has much more to do with us as individuals than with our doctors or the health system. So I will start from drugs because that's the easy bit. And thank God we now have an awful lot of drugs which can help us control inflammation almost completely nowadays in most patients with rheumatoid arthritis, if we do our job right. And I think in most cases, we are doing it right. So one part of reducing the risk for heart attacks or strokes in people with rheumatoid arthritis is to achieve as good control of inflammation as possible. And this nowadays is doable in most people. And we have a lot of very effective drugs, but not only individual drugs, strategies for achieving this. I'm not going to talk how exactly. This is something that I'm sure you have all experienced and you have all discussed with your individual doctors. However, we as rheumatologists could become a bit smarter about how we use anti-rheumatic drugs. For example, I'm sure some of you may have taken or still be taking a drug called leflunomide for your rheumatoid arthritis. Leflunomide is a very good drug for arthritis. It has a possible side effect, which is to increase blood pressure. Okay. If we have a patient who happens to have hypertension already, and it is difficult to control, then possibly leflunomide should not be the first choice drug to use for control of their arthritis, since we have so many other drugs that we could use instead. You see what I mean? And we now have several classes of anti-rheumatic drugs, and we can be much smarter about which ones we choose for what person, depending on their overall profile, not only their arthritis profile, but also cardiovascular or even other problems. It's not only cardiovascular disease, which can happen together with rheumatoid arthritis. And then on the other side, we have an awful lot of drugs to control blood pressure, to lower lipids, and to control blood glucose. And I'm not going to go through them. If we as rheumatologists do not have the expertise to manage such drugs, thankfully, there are many other experts who can help us with this, like cardiologists, like metabolic physicians, and of course, the general practitioners who are extremely good at doing this, okay, as long as they know that there is a problem, and as long as they communicate with your hospital doctors to know what each of them does. Now let's move to the more difficult bit, because we all find it easy to take a pill or 2 or 6 if our doctor gives it to us. But we all find it difficult to change our lifestyle. And we have shown that by having such meetings like this, by educating both people with rheumatoid arthritis, but also health professionals, and even by helping with behavioral interventions such as cognitive behavioral therapy, such as educational leaflets, such as websites, we can achieve some changes in behavior which can reduce several heart risk factors. For example, blood pressure. We have done this in randomized controlled trials in the same way that we use drugs and use a placebo to say whether we can have the desired effect. We can do such studies with such interventions, and we've done them. This is obviously an old slide, and Elsa is going to kill me for still using it, but these are interventions that NRAS, for example, delivers, okay, to help people achieve things themselves. And it's something that we need to develop because, to be honest with you, whether there is coronavirus around us or not, this is the future. A lot will be delivered in such formats in the future, whether we like it or not. We can stop smoking. And you may find it surprising, but about 1/4 of people with rheumatoid arthritis in the UK still smoke, even though they know, or they should know, that smoking is not bad only for the heart and the blood vessels. It's not bad only for the lungs. It doesn't cause only cancer, but it is a risk factor itself for having rheumatoid arthritis, and it is a risk factor for not responding well to the treatments we use for rheumatoid arthritis. And again, we should be investing in programs that can help us stop smoking. And then we have exercise. And this is our Action Heart Center in Dudley. I think Elsa has visited it several times and has seen it, where people with rheumatoid arthritis in our place go there and they exercise under supervision by expert exercise physiologists. And we have seen examples of people, literally, I'm not making it up, walking in there with a Zimmer frame and 3 months later exercising independently. And by doing this, to have had massive benefits for their function, their body function in terms of arthritis, but also for reducing their cardiovascular risk. This slide is deliberately in Greek because I'm Greek, but it is about the Mediterranean lifestyle, not just the Mediterranean diet. The Mediterranean diet is the only diet which has a sufficient body of evidence behind it that it reduces cardiovascular risk. But it's not only the diet that matters, it's the whole lifestyle, which is this: sitting down with a company, enjoying your Mediterranean food and your Mediterranean drink. Socializing is extremely important for reducing stress, which is also extremely important for reducing blood pressure. So we should consider all of this in its entirety, not little bits and pieces. So this is the information that I've tried to put together, and I hope you got an idea of how complex, but at the same time, how simple this all is. In a way, what it takes is you, your immediate family and social environment, and your doctor. You and your immediate social and family environment can work on lifestyle changes. More physical activity, not necessarily structured exercise. The more, the merrier. Better dietary habits. Different ways of socializing which can help reduce stress. All of these things are conceptually the same for us, but they are different for each of us. And only we can find what works best for us. And then the other component is what your doctors and the NHS and NRAS and other support groups can do for you. So what I'm saying here for the clinician is almost the mirror image of what you should think yourselves, and challenge your doctors, challenge your other health providers, challenge NRAS itself to try and provide. It's important for us doctors to understand, and it's important for you patients to understand, that we do not treat diseases. We treat individuals who have a problem. There are no two people with rheumatoid arthritis that I know who have exactly the same rheumatoid arthritis. They have exactly the same, I don't know, cardiovascular risk factors. They have exactly the same family, social, other support environments. They have the same access to NRAS or to the NHS facilities. We treat the person we have in front of us, we should treat the person we have in front of us in his or her entirety. We are not treating his or her rheumatoid arthritis. And this is something you should also expect and demand from your healthcare providers. We as doctors must be aware of what we call comorbidities with other conditions like heart disease, which can happen with the primary condition, in your case, rheumatoid arthritis. And we should be, as doctors, aware of the significance of these comorbidities. But you also have the responsibility to be aware of these comorbidities and take ownership of them and point them out to your GP or the rheumatologist. And when you say, what are you going to do about my joints? Also say, what are you going to do about my heart problem or my blood pressure or my cough? Because it is your right and because it is the right way of approaching a problem. The problem of the individual, not the disease. We are not treating rheumatoid. We should not be treating rheumatoid arthritis. We should be treating the very specific person who is in front of us who happens to have rheumatoid arthritis. We as doctors and as a health system need to develop strategies to assess the primary disease, in this case rheumatoid arthritis, but also the comorbidities. If you go to your hospital and your rheumatologist or the nurse specialist counts your joints and tells you your DAS28 score is good, it's 2.6, well done, it was 4.2. You must tell them, okay, thank you, great, excellent, I love it. What's my blood pressure? Can you measure it, please? We need to develop the systems. You need to expect and demand that these systems are in place as individuals and jointly as MRS. We as doctors need to consider all therapeutic options that are available. As I said, we have an awful lot on very good drugs, but the best drug is not good for everybody. And if something doesn't work in person X, may work very well in person Y and vice versa. But in the same way that I mentioned it before, you will challenge and you should challenge me when you come to see me and you tell me, listen, doctor, you've given me this or that drug now for 3, 4, 5 months, and I still wake up every morning and I cannot close my hands. In the same way, you should have in mind to challenge us about what we do, in this case, about heart disease risk factors, like blood pressure. You can tell your rheumatologist, thank you, this has worked or it has not worked, but you know, I also have a blood pressure which is not well controlled. Can you do something about it? And your rheumatologist may not be able to do something about it because they don't have the expertise, but definitely it is our job to communicate them with people who have the expertise, your GP or a cardiologist, and say, look, sort this out, please. We must inform you and we must make you partners in your management, in whatever we do for you. But again, it is up to you to expect this from us. And different people are different. There are people who are very happy with being told, take this pill and come back in 3 months and tell me how you are. And there are other people who need much more information. They need much more education. And this is increasingly so, and I think this has resulted in very significant improvements in our communication and in you realizing that it's not worth doing something if you don't do it the right way. And you realizing also that if you come and tell me that you've been taking your methotrexate, let's say, but you have not been taking it, I will not be able to interpret what I say in front of you. We should not feel intimidated or scared of each other. We should have a very open relationship, and we should both understand that we are in this together. we cannot do our job well if we don't involve you, and you will not have the best possible outcome if you don't inform us and you don't expect us to inform you about whatever we are doing. And I finish this for all rheumatologists, that we really need to be excellent general physicians to be a good rheumatologist. Heart disease is a problem, fair enough, it is, which happens not only in people with rheumatoid arthritis, but in everybody. But other things can happen also, like lung disease, like skin disease, like drug reactions. A rheumatologist needs to have a very wide knowledge and experience of all of medicine, really. We are the last good physicians, I believe. And you should also believe that your rheumatologists are usually very good doctors, not only for the rheumatological problem, but for everything. But you also need to observe yourselves. And if you notice something new, let us know. I'll leave it at that. Thank you very much. I hope I put some messages across. I'd like to thank an awful lot of research fellows and collaborators who have worked in this field, and a lot of people who have helped us with funding to do a lot of this work. And I would like to thank again EMRAS, because you have facilitated a lot of this research activity for more than 15 years now, I think. How long? Since the beginning, I reckon. Thank you very much. Thanks.
We have a couple of poll questions before we go for our comfort break that George asked us to launch. All you need to do is click your answer and then commit, and then click submit. And then I can, all of it is anonymous, by the way, so, but then I'll share all the results. So the first question is, did you know RA can affect the heart and other organs? So yes or no? I always find it so interesting because I can see everybody click it. So it's all live. I can see it all kind of change. I'll leave it for a couple more seconds and share the results. So 96% of people said that they did know that it can affect the heart and other organs. And if I stop sharing that, we'll just quickly do another one. And this one is, do you think medication use can affect the heart? So whether that's positively or negatively, just whether you knew the medication could. So go in, and I will end it now. Share results. So 70% of people think that it does affect the heart, and 28% aren't sure. So the next one is, do you get your blood pressure measured when attending appointments? But it's, share results, it's 50-50. Then one last one really quickly. Do you do regular physical activity? So that's not just, you know, going to the gym or going for a run. That includes just the general housekeeping, gardening, just for a walk, anything like that, that includes. And 94% of people said that they do. So that is great, thank you. And thank you everyone for answering all of those. That is all the poll questions done now. So first question, George, I know it was kind of covered in your presentation, but can you summarize which RA medications pose a greater risk of cardiovascular disease risk assessment, kind of, i.e. steroids, biologics, DMARDs, kind of, etc.
Sorry, which are the worst treatment? Which?
Pardon, sorry?
Can you hear me?
Yes, yeah.
Yeah. Which anti-rheumatic drugs are worse for heart disease risk factors? Is this the question?
Yes, I think so, yeah.
Okay, right. Well, I would probably say that the worst, if used at higher doses, and by this I mean over 7.5 milligrams per day, and for long periods of time, and again, by this probably I would mean more than 6 months, is corticosteroids, prednisolone. And we do have other drugs that can help us control the disease quite effectively nowadays, and we should try to minimize exposure to prednisolone. Then the next worst, I suppose, would be the anti-inflammatories, the non-steroidal anti-inflammatories, but again, if they are used in a prolonged way, most likely. Now, if we take a tablet or two every now and then, it doesn't really matter, and it's much more important not to be in pain, be able to do things, than to be in continuous pain for not taking drugs. From then on, I don't really think that we can separate the drugs between themselves. Most anti-rheumatic drugs, whether we talk about the traditional ones such as methotrexate, hydroxychloroquine, even leflunomide, etc., if they are used carefully and they have the desired effect, so they control inflammation, overall their effect will be positive. And the same applies to biologics. I'm sure a lot of you know that some biologic treatments, possibly all of them, to different extents, can affect lipids. So you take biologic drugs, X, Y, or Z. I noticed there is a question about tocilizumab lipids, and you see that lipids go up. Well, there are studies which show that even if this happens, the overall effect of the drug is actually good for heart disease. Presumably because it controls inflammation very effectively, and that component of the heart disease risk gets better, gets reduced. I would put all of the other drugs roughly in the same region. I would not worry that much about their adverse effects on cardiovascular risk factors, as long as they are monitored and, if necessary, managed appropriately. I would consider them mostly protective rather than dangerous from the cardiovascular perspective.
Great, thank you. We have, do you feel you should be who do you think should be carrying out cardiovascular risk assessments, the GP or the rheumatologist?
I genuinely do not know the answer. I have been agonizing over it for 20 years. I have been trying to set up systems and strategies locally and nationally, and all of them have failed. I think that the best place to do it is the rheumatology department, because this is where people with rheumatoid arthritis go regularly. They know the staff well, and it's actually very, very easy to get a blood pressure measured, a urine checked for glucose and protein, that's all you need, and to have your lipids assessed every now and then. So I think that by far the most effective place and efficient way to monitor risk factors is the rheumatology department. If we forget about funding and costs and such things, because this is where the argument is. It's not really who does it. Everybody can do it. The real problem in the NHS is who pays for it. That's the bottom line. Claire and Elsa, okay, that's the bottom line. So I think that for monitoring, definitely the rheumatology department is by far the best, by far. Now for treating, that's a different question, because there are rheumatologists who have the expertise, have sufficient knowledge and expertise to treat blood pressure and lipids, etc. But there are others that may not have it. So the next question is, okay, once the risk factor is identified, who treats? I think that for this, actually the GP is the best person, as long as they do the job well and they do it right. And why are they the best people? Because GPs definitely have the expertise to treat blood pressure and to treat lipids. They do it in the general population. They do it for all the diabetics. They even get paid extra money if they do it well for diabetics. So why shouldn't they do it for people with rheumatoid arthritis? Again, I do not know. And again, I think that it's money. If somebody told them do it for rheumatoids and we'll pay you as much as we pay you for the diabetics, they do it and they do it well the next day. So this is my politically incorrect answer to your politically correct question.
Thank you. I think Elsa, you have a question.
It's not so much a question. This is the problem that we've debated many times, isn't it, George? Is who is going to do it? Who's going to manage it all? And I agree with you. But last week I was called into the GP for my annual RA health check. And normally this is just a 20-minute chat where they don't measure anything, and it's about as useless as a chocolate fire guard. But actually this time I had a physician's assistant who was doing it, and she was all fired up. She'd got a Q risk 2 ready. She's ordered a lipid test for me tomorrow morning. And, you know, I thought, my God, what's happened here? And it looks like they've got some kind of shared care arrangement with my hospital to do this now. And where they measure things, and that's the important thing. So maybe something is changing in the UK. I'm not sure whether this is just a one-off that's happening in my surgery or whether it's something that is with the appointment of these physicians' assistants is actually going to be more widespread. But I totally agree with you. In fact, if we could get you to do this presentation to all doctors in training, George, that would be wonderful. Get it on their radar early.
And sorry, Elsa, I did not catch it. Did you have this at your GP practice or the rheumatology department?
At the GP practice.
Excellent.
Yes.
Thank you, Elsa. We have a question in, I believe it could be from one of the poll questions, but someone asked, how often should blood pressure be taken?
If it is for screening purposes to see if one has a high blood pressure or not, and you take it a couple of times and it's normal, then probably it should be repeated every few months, irrespective of what medications you are taking. And certainly I would measure it another couple of times after every significant change in medication. If I changed a treatment to a different drug or something, I think it makes good sense to have your blood pressure measured a couple of times to make sure that it remains normal. Now, if your blood pressure is not normal, so it's high, it's a very big question how often it should be measured and even how it should be measured. The current guidelines of the hypertension societies around the world are actually that it's better to measure your blood pressure at home in different circumstances and days and hours of the day and days of the week than to go to the doctors and measure the blood pressure. And this is what they consider the best way of measuring the blood pressure. And in order to establish a diagnosis now of hypertension, you need to have daily measurements at home, ideally, recorded, and then you go to your doctor with them and they decide, okay, you have blood pressure, high blood pressure or not. And the next step now, unfortunately, nothing is simple in medicine and in health, is okay, once you've been diagnosed or I've been diagnosed with hypertension and I start treatment, I need to make sure that the treatment works well. And again, the best way to do it is to have regular, probably once weekly, blood pressure measurements at home, again, according to the new guidelines. And then after about 3-4 months, go to the doctor with the measurements and see whether they consider that the blood pressure is appropriately, sufficiently well controlled, or you need some change in medication. So it's a long answer to a short question, but the bottom line is that it's best to measure blood pressure at home and not at your doctor's. According to the guidelines, we are still measuring blood pressure most of the time at the doctor's. And once you have started medication for blood pressure, if it's necessary, then I would reckon once a week initially to make sure that the medication works well is sufficient.
Great, thank you. I will quickly ask a couple more pre-submitted questions. I can see that people have got their hands up, so I'll come to you just in a bit. I'll just quickly ask some more of these ones. Someone has said, I understand that moderate exercise is generally beneficial to RA sufferers for so many reasons, including cardiovascular health. Please, can you say whether endurance exercise is beneficial to the cardiovascular system or does the law of diminishing returns kick in?
Okay. I can give you again a scientific answer and an opinion. The scientific answer is that I cannot answer your question because there are no studies assessing endurance, the effects of endurance exercise on cardiovascular health in people with rheumatoid arthritis. The opinion is that any exercise is good exercise as long as it is done in a good way. And the good way means that there is sufficient warm-up for whatever exercise one wants to do. Then the exercise is performed in a technically proficient fashion, which we cannot know from day one, but we can learn as we perform the exercise. So, for example, going for endurance running, wearing your work shoes probably is bad technique and it will cause problems definitely to the joints. Okay, and then the third rule is really the cooling down period with a lot of work for extensions, etc. And these are particularly important for people who have any type of musculoskeletal problems, including rheumatoid arthritis. Now, if endurance exercise is performed well, I suspect that the cardiovascular returns are excellent. I also agree that after a while there is a law of diminishing returns. That means that how much endurance is endurance. So 1 or 2 hours running is endurance, but there are people who do 24 hours running, others who do even 2 days running continuously. I don't think that you have extra cardiovascular benefits beyond a certain duration. That's again an opinion. I'm sure there are studies of this in athletes, but I don't really know them in detail. Something that I could look up, but I'm equally certain that there are no such studies in people with rheumatoid arthritis.
Great, thank you. We have 3 people with their hands up, so I'll quickly go to them, and then I have a couple more, and then we'll pass over to Elsa for you. So Caroline, could you ask your question? I think I've just asked you to unmute. If you could do that.
My question is, who should be filling? I mean, they used to call them sick notes years ago, fit notes. I was diagnosed in 2018, and my GP was doing the fit notes for quite some considerable time. And then a little while ago, he said it should be the responsibility of the rheumatologist. And the rheumatologists were like, no, we've never done the fit notes. And the GP was like, well, something changed, and it's the responsibility of who you're under the care of. I think it is going to start being the rheumatologist, but why did I get stuck in a sticky situation with me being the one going from the GP to the rheumatologist and backwards and forwards to sort it out? Who should be doing the fit notes for us if we need them, the rheumatologist or the GP?
Can I come in on that? I think probably that's going to be an arrangement between your specific hospital and the local GPs with the CCGs. It's not a blanket right across the UK situation. So Caroline, if you want to drop helpline at NRAS an email with that specific query with the unit that you're in, we'll make some inquiries for you to find out what's happening.
I live in the Derby area, and my GP said that there was an NHS, is the word review? I don't know, change in 2017. So whether somebody, I don't know. Like I say, I feel like the patient who's stuck in the middle here.
Yeah, that's often the case, unfortunately.
And it's you know, it's not nice. I don't want to fall out with my team that's looking after me. Yeah. I don't want to come across it, and I'm like, well, you know. So yeah, I'd like to know an answer to that. And I've asked my question, and I feel ever so rude because I'm going to have to go because I'm nearly falling asleep. I'm quite fatigued.
Oh, well, but the heat is making us all fatigued. Don't worry about that at all, Caroline. Yeah. We'll take that offline. I think for George, this is not a question he'll be able to answer in this one.
Okay, right. Okay, thank you. Thank you.
Thank you, Caroline.
Thank you. And then we have Patricia, if you could unmute yourself and ask your question.
Okay, can you hear me?
Yes, we can, yeah.
Yeah, I've been taking simvastatin for quite a long time, probably about 20 years, since I was fairly young, because my cholesterol was fairly high, not stratospheric, but quite high. And then I subsequently, about 4 years ago, was diagnosed with rheumatoid arthritis. But I've never had a test done. As far as I'm aware, none of my blood tests, which I have quite frequently, include checking my cholesterol. So if I go to the doctor and say, look, I really think I ought to have my cholesterol checked, once I've got the, you know, the whatever it is, who's going to evaluate the dangers, as it were, because he won't necessarily take into account all the things that you've said about heart disease. So how do I approach that?
Well, it's a very good question. First of all, I'd like to say that we should put things in their real perspective. I don't want you to leave this session worrying that tomorrow you'll have a heart attack or a stroke because you have rheumatoid arthritis. This is not true. Statistics just tell us that your risk is a bit higher than mine. That's it. But we cannot say what will happen to the individual person. So we need to follow some guidance. Now, the issue of awareness, how well your GP or even your rheumatologist knows this field, is a big issue. There are definitely still rheumatologists who are not particularly aware of the importance of heart disease, and there are definitely many GPs, many more, who are not aware of this. I think, and what we've been trying to operate locally is whole programs to increase awareness between rheumatologists and GPs, and then increase communication with them. What I have been doing when I was seeing still patients was to write to the GP and say that, look, this lady has rheumatoid arthritis, her LDL and HDL are such and such, her calculated risk for a heart attack is such, and I think she fulfills criteria for primary prevention. And then let them start the statin and monitor the statin. So what I was trying to achieve by doing this was first to increase awareness that the problem exists generally, and second, to guide the specific person's management. The way you can approach it, but I don't think you particularly need to be particularly worried because you are already taking a statin for 20 years or so, is to discuss it openly. So, for example, this could be an opportunity. You can go to your doctor and say, look, yesterday or last week, I was in a webinar of NRAS and I've heard these things about heart disease. Are we doing anything about it? Because I've had this problem with lipids. You see what I mean? This is what I mean, that all of us as patients can take some ownership of the more general problem, apply it to ourselves and into our local situation. And by doing so, implement change. If you talk to them like this, they will have to say something about it.
Well, yes, it's getting to talk to them at the moment, isn't it? I mean, you know, rather than on the phone, even just getting through the door.
That is correct. But let's all hope that this will not be like this in a few more months.
Okay, right. Well, thank you.
Thank you for your question, Patricia. And then there's one more person with their hand up. Jane, if you could unmute and ask yours.
Hello, George. What on your slide you showed total cholesterol 6 was your cutoff on that slide you showed for a 65-year-old woman or whatever. Is 6 the value that you use if you're thinking of somebody with RA, or are you looking at a much lower level now for somebody with RA?
No, first of all, the exact units that are used depend on the health system. So what we measure in the UK and what we measure in Greece, where I am at the moment, and in mainland Europe, and what they measure in the United States are 3 completely different units. And we have a translation from one to another.
Okay.
The real answer to your question, though, is probably much simpler. The absolute levels, irrespective of the units, are important, but they are not as important as the ratio between the good and the bad cholesterol. Okay.
Yeah.
There, everybody agrees that if your total cholesterol divided by the HDL, the good cholesterol, is less than 5, that's generally okay. And if your LDL, your bad cholesterol, is divided by the HDL is less than 3.5, that's reasonably okay. Now, whether we should apply stricter criteria for people with rheumatoid arthritis is a good question. This is something that we have tried to address. And the bottom line is that the lower the cholesterol, the better it is, generally, not only for people with rheumatoid arthritis, but even for the general population. But then one needs to consider also how this is achieved, because it is different to a certain extent for me to take high dose statin, 1 tablet and nothing else, and different for a person with rheumatoid arthritis who is already taking another 10 drugs for other reasons to take high dose statin. Having said this, we have proven beyond any doubt in the TRACE-ARray trial that we did for several years that statins are quite safe in people with rheumatoid arthritis, irrespective of what other drugs they take. So they can be used safely. It doesn't mean that they can be used without monitoring, but they can be used safely to lower the cholesterol as low as you want. But I reckon that a LDL to HDL ratio of less than 3 in people with rheumatoid is perfect.
Okay. Are there any other cholesterol lowering drugs rather than statins?
Oh yes, there are. There are quite a few different drugs. There are now combined medications which contain a statin plus other classes of drugs, and there are even new drugs coming out.
Okay.
Most of the time nowadays, we don't have a problem to find a drug to lower cholesterol if we need to. But you shouldn't be concerned about statins at all, and you shouldn't be listening to the bad press that statins have gotten from the same and the particular part of the press all the time. We do not have any concerns at all.
Just to say, yeah, the Daily Express and the Daily Mail probably are not the best place to pick up this right information.
I never read those.
Their headlines are often quite different.
No, I agree. Yeah. Okay, thank you very much.
Great, thank you for your question, Jane. I have a couple more before we pass over to Elsa. Do you advocate the use of coenzyme Q10 to reduce the risk of cardiovascular disease?
No, I don't. Simply because I don't think that there is sufficient evidence and sufficiently robust evidence. I think we may have good theoretical reasons to believe that X, Y, or Z, whatever it's called, may have beneficial effects on the cardiovascular system or the joints or whatever, but all of these things should really be subjected to proper assessment in properly designed trials to say that yes, it's good, or no, it's no good. We've had, you know, coronavirus has taught us a lot of lessons very, very quickly. And when I say us, I mean us as the general public. Initially, we thought that hydroxychloroquine was the wonder drug and it will save lives. The studies were done and it doesn't do anything. Then we thought the same about colchicine, same again, and several others. we may have good reasons to believe that something is helpful, but unless it is properly tried, unless it's properly assessed, I don't think we should be recommending it or advocating it, etc.
Great, thank you. And then just one really quick one before we pass over to Elsa to do a couple that she has. Are there any differences in the cardiovascular effects on seronegative versus regular RA?
Very, very nice question. You are asking specifically whether drugs have different effects in seronegative RA compared to seropositive RA. The answer to this is that, as far as we know, no, they don't. If part of the question is to ask whether, in terms of cardiovascular risk, seropositive RA behaves differently to seronegative RA, then we do have some evidence to suggest that seropositive RA is, let's say, a little bit worse for the cardiovascular system than seronegative RA. We don't know exactly the reasons this happens, but from the epidemiological perspective, it appears to be like this.
Great, thank you. And now I will pass over to Elsa to just ask a couple more before Claire says a few things just to close off.
Hi, George. One of the things that when I visited up in Dudley that I had done was to do an ultrasound of the carotid artery to look at atherosclerotic plaque, which you talked about in your presentation. Is that a test that you think would be feasible or practical to do for people? And if so, again, who would do it? Are there sort of guidelines that you would think, you know, you've got to have had RA for so long or be of a certain age where they would start to do this kind of test? But do you think that would be something that would be helpful?
Well, I was discussing this earlier in the chat room. It's a very good and it's a very important question. How do we actually screen people for heart disease? This applies to everybody, but let's discuss specifically people with rheumatoid arthritis. One of the problems for people with rheumatoid arthritis is that sometimes they have heart disease, but they do not have any symptoms of heart disease. This happens also to the general population, but not as often as it happens in people with rheumatoid arthritis. So, if I have chest pain and I go to the doctor, or if I have breathlessness when I walk and I go to the doctor and tell him or her that, they will definitely put me in a route that they will investigate several things. So they will do an ECG, they will do an echocardiogram, they will do an exercise test, they may do a carotid ultrasound, etc. Why? Because I have the symptom that suggests that I have cardiovascular disease. But when I'm in a situation where a lot of the people I manage may have heart disease, but they may not have symptoms for it, I need to think of ways of detecting this heart disease before they develop symptoms, because they may never develop symptoms, or they may develop symptoms when things have advanced a lot. And there, we do have a very good example, and this is how people with diabetes are managed. So people with diabetes, because diabetes is accepted by everybody, that it is equivalent to having heart disease, every year need to be screened in a very specific way about whether they have or they do not have heart disease. So, for example, diabetics will definitely have their blood pressure assessed, they will definitely have their lipids assessed, they will definitely have their glucose assessed, they will definitely have an annual examination of the eye to see if in the back of the eye there are vascular changes, which is a very good indication of heart problems. And they may well have a carotid ultrasound or even peripheral vascular ultrasound. And they may well have an ultrasound of the heart, an echocardiogram. This is established practice for people with diabetes. It could be established practice for people with rheumatic diseases. If it is accepted, what we are trying to get accepted by everybody, that this is a real problem. And if the money is found to do it. Now, we could discuss, but I don't think it's the right forum to discuss, which would be the best screening tests. But that's why you have expert committees, and we can sit around the table and we can shout at each other, but at the end of the day, we will decide that this is the way we go. And 3 years later, once this has been tried, if it is not successful enough, we'll change it to something else. That's how this works. But the bottom line is that we are not even there yet. There are people like me and many others who advocate for ages now that we should have standardized screening systems that the NHS can provide for, because the real problem is again the money. It's not who does it and what they do. We know exactly what we can do. But if you say that suddenly 1 million people with rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, lupus, etc., need screening, who will do it? And who will pay for it? That's the real problem. But we should keep trying it. NRAS should keep pushing.
Sure.
Yeah.
That sounds like a good campaign to me.
Yes, thanks, George. That's our challenge accepted. Have you another question, Elsa?
And just a quick one. If like many of the people on this call, like me, are of a certain age, shall we say, and have had RA for probably quite a long time, is there a sort of age correlation? You know, if we've been on drugs for a longer time, we've had it for a longer time, are we more likely to have even greater chances, or does our risk level stay the same as somebody who has perhaps only been diagnosed for a year? Are they the same, or are they? I kind of assume that they must be more, but it'd be helpful if you could just clarify that.
Yeah. Again, the bottom line is that the older we are and the longer we have had rheumatoid arthritis or other inflammatory conditions, the higher the risk is to have heart disease. Now, as regards older, this applies to the general population as well. The older one is, the more likely it is to have a heart attack. Full stop. I'll leave it at that because it gets a bit complicated for early disease. Okay. Yeah.
Okay. Thank you, George.
Thank you so much. I realise we're on time, and thank you so much. You know, over 70 people have stayed on listening, and this will be recorded, as we said, or has been recorded, so we will be able to share, so you can watch back and And I know on a very hot sunny day, yes, believe it or not, George, you're in Greece, we're in England, and we're probably experiencing the same temperatures, which is just quite remarkable. It won't last here though. So a huge thank you for spending so much time with us today, answering and making quite complex health information accessible to lay people like myself to understand. So I really, really do appreciate that.
Yeah.
Bye, everyone.
Bye, thank you.
Bye-bye.